Oh, well, Santa Fe Group was a vision in Dr. Meskin's eye, and he had he was kind of a Renaissance man, and he had taken a sabbatical. He was a professor of public health and epidemiology at the University of Minnesota, then went on to be dean at the University of Colorado. But when he took his sabbatical, he went to the College of Santa Fe and studied the great books. And there he kind of went back to the European salon, where people would come together, they would think about an issue and discuss it and basically try to develop innovations to change the world they lived in. And Larry had a vision of, wouldn't it be wonderful if we could do that for dentistry, if we could bring together leading, dental thinkers, scientists, educators, to think through, policymakers, to think through various issues in oral health. And then basically try to stimulate change, not necessarily to implement the change themselves, but to basically seed the idea, and give the idea to organizations so that they could take and run with it. And I think looking back now, I think he's been very successful. Well, I was essentially a public health dentist and started my career in the Indian Health Service, the U.S. Public Health Service Division of Indian Health, taking care of primarily children in a little town, Tallahena, Oklahoma. And basically when I saw patients, and this was a non-fluoridated community, so these are children with very high caries rates, and I looked around at the field, what was interesting is the children were coming in and often their grandparents were bringing them in. And while we provided care for the children, the grandparents needed dentures, and we weren't doing a lot of that because our workload for the children and their parents was so great. And I thought, oh my goodness, here are adults who've worked their whole life, they've raised their children, and now they're raising their children's children or helping, and we can't do anything for them. And I looked around at my public health colleagues, and they were all worried about caries in kids. And also it was the late 70s, and it was right after Richard Nixon was talking about a national health insurance. And in the mid-70s, national health insurance seemed imminent. Gee, how funny, 35 years later. And when people were talking about national health insurance, they were talking about primary care for children and dentures for older adults, for seniors. And I'm thinking, that's the wrong incentive. You don't ever want to have an insurance program that incentivizes people to lose their teeth. So I said, enough of my colleagues in public health are worried about tooth decay in children, but nobody's talking about that older population. I think I'd like to get involved and interested. Went back, did a dental public health residency with Chet Douglas at Harvard, and we focused on older adults and developing a needs-based model for delivering oral health care to older adults. And the rest is kind of history. Just kind of got involved more and more. I guess first of all, I'd like to reconnect the mouth to the rest of the body. That if you have health insurance where dental care is part of it, that it's not separate. Maybe you buy it from a separate company, but if you're going to have health, like car insurance, you don't have car insurance that only insures the transmission and the tires. You have car insurance for the whole car. So let's have health insurance for the whole body, not just for 95% of the body, and we forget the 4 cubic inches between the lips and the oral pharynx. So that's my first thing. Secondly, dentistry as a whole needs diagnostic codes. We need to understand, we do really good with the treatment, and we have treatment codes, but we need to teach our students that the reason they're doing this treatment is for the diagnosis of some disease. And that's the piece, and we've heard several people mention this today. We need to diagnose, we need to have diagnostic codes to say, okay, this is a diagnosis of non-restorable caries, and that's why we're extracting the tooth, or that's why we're providing the treatment that we're treating. So first of all, dental students understand that it's the thinking they do on behalf of the patients. That's the most important contribution that they make to the patient's health. Secondly, if in fact we do implement a treatment or a course of preventive therapy, we have a code, a diagnosis to match it. So there are two of the things. Then third, it makes me crazy that in the treatment and the delivery of care, that the diabetic patient, for an example, has their diabetic eye disease treated, their diabetic cardiac disease treated and reimbursed, their diabetic foot disease treated and reimbursed, but their diabetic gum disease may get treated but doesn't get reimbursed. Now, how can you treat the person's disease and not treat all of it? You know, the patient with the stroke or the patient with the dementia, you know, everything else gets treated except their oral health. So reconnecting the delivery of care with the medical arena so that we have teams, we have geriatric teams, because I believe the dental professional can educate the health professional as well as the health professional educating us. So I think it works both ways. So those are my three big things. I believe in the power of the patient to understand their condition and make decisions. And I don't think we've tried to reach them. If you look at the one innovation in dentistry that changed overnight, is all of us in dentistry wore gloves. Why did we wear gloves? Not because we necessarily believed it, but the patients expected it of us. And I think if we teach patients about oral health, 50% of their payment for dental care is coming out of their pocket. The other 50% is from their dental insurance. They understand, they're paying for this service. I think the more information we provide, I think people will understand and grasp this concept. I don't think any family should pay $3,000 to $4,000 to $5,000 a month to put their family member in a nursing home, only to watch the beautiful dentistry that they have or their beautiful smile disintegrate in 6 to 9 months. That's elder neglect. That's elder abuse on the part of the nursing home. That's unacceptable care. But unless dental professionals let patients know that you shouldn't expect that, I don't think they're going to know. So I believe in the power of the patient, the power of the consumer. I think if they have information about oral health, I believe they will act on it, and they will act on it in the right way. They will do the right thing. Teeth were designed to last a lifetime. You shouldn't lose, nobody's ever lost a tooth because they've had a 75th, 85th, or 95th birthday. They lose teeth because they have disease, they have tooth decay, they have gum disease. That's why you lose teeth. And dental diseases are preventable. My third message is dental diseases are preventable. We know the risk factors. We know tooth decay is a bacterial disease. Periodontal disease is a bacterial disease. If you can control the bacterial populations, we can control these diseases. I guess the one would be medicines. You know, doctor, what medicine are you giving me? Will this medicine affect my oral health? Will it cause oral dryness? If it's a bisphosphonate, does it put me at risk for osteonecrosis of the jaw, serious jaw infection? Does this cause a gingival overgrowth like the antihypertensive medicines or the seizure disorder medicines, the Dilantin or that type of medication, or the immunosuppressive drugs? So ask patients, will this medication cause bleeding? You know, Plavix, for example, causes bleeding. People who are on Coumadin after they've maybe had a stroke. And then they take an aspirin and vitamin E, and all of a sudden you have a lot of bleeding. So people, you know, people need to understand the medications. I think the inflammation is another piece. You know, how do we reach them to understand that inflammation, particularly in the mouth, can cause serious problems in other systems? So maybe making sure if C-reactive protein is the measure. I like the idea of having people understand their hemoglobin A1C. Are they at risk for diabetes? It has an oral health effect. I think dentists should be asking them and taking that measurement in the office. When I see a patient clinically, what are the things I worry about? Well, do I have to give them antibiotics because of the joint? Do they have a heart problem that I've got to put them on antibiotics for? Are they taking medications that could affect their oral health? So we need to ask them about medications. And do they have a chronic disease that affects their hygiene ability? So do they have serious rheumatoid arthritis? Have they had a stroke? Do they have dementia where you put the toothbrush in their face and they don't know what to do with it? So that are the things that, you know, when I see a patient clinically, that's what I worry about. So maybe they're the 4 things we need to put on the car.